Hello and good morning, everybody, and welcome to the 14th Child Health Priorities Association Conference. My name is Haroon, Saloojee, and I'm going to be co-facilitating the first session this morning. My co-facilitator this morning is Professor Ute Feucht, who more importantly is also the chairperson of the South African Child Health Priorities Association. So it's a great pleasure to welcome Ute to open our conference. Ute, over to you.
Yes, thank you, Haroon, and good morning to everybody. Thank you for joining in. It's really my very big pleasure to welcome you all and to open this conference. As Haroon said, this is our 14th South African Child Health Priorities Association conference. We are, as you obviously realized, online this year, and we will have discussions around venue for next in-person conference tomorrow at our AGM, because obviously it is also fantastic to meet in person. But this year we are virtual, which means we'll take the good and the bad of that. It means that many people can join in from all over the country, and yeah, so that's obviously the big plus. But we will have to work a bit on making this conference interactive, despite us not being together in one room. But we really invite you to come along on this 2-day journey with us. The theme, as you would have seen, is South Africa being just past the halfway mark for the SDGs. So are we on track to meet the child SDGs? And what can we do to make that happen, to move the needle in terms of improving the outcomes for our children? So as per program, we are today and tomorrow from 9 to 11 and from 2 to 4 in the afternoon. And then there's the AGM tomorrow at 1 o'clock. And please also diarize that. We need you to come to that AGM. It's really, really important that we discuss what we want to do and what we want to achieve with this Child Health Priorities Association. Yeah, so we have fantastic sessions lined up, from maternal and child mortality, emerging child health challenges, childhood development, child pertinent SDGs, and then research abstracts. And you would see that we actually have three breakout rooms for the research abstracts, because we had so many abstracts. So thank you for everybody who submitted their abstracts, and thank you for the speakers. So we have got 195 delegates, including 28 guest speakers. So we are really geared up to have a fantastic 2 days together. So again, very welcome. Please just mute your camera, mute and put off your cameras, but use the chat while we are in the conference sessions, that we can really engage and that we can interact, learn from the data, so that we can plan for our future, for our children, and that we also have fun together. So very welcome. Over to you, Haroon.
Thank you very much, Ute. So I think many of the people who are attending, the delegates who are attending this conference, have been attending conference previously, and we welcome you back. You would know that UNICEF South Africa has been a partner to the Child Priorities Association through all the years, from its inception of the first Priorities Conference way back in 2007. And so we've obviously been happy and delighted that UNICEF has continued to partner with us, providing both technical support and financial support. And without their assistance, I'm not sure we would be able to hold the conference as we have. So to get the proceedings going, it's a great pleasure then to invite the UNICEF South Africa's current head of health and nutrition, Dr. Sufang Guo, who's going to tell us a little bit about UNICEF's approach to the SDGs, particularly as it relates to children, mothers, newborn children, and adolescents. So Sufang, let me invite you to please go ahead and start your presentation.
Hey, good morning, colleagues. Should I share my screen?
Yes, please. And Sufang, if you do have a camera that's functional, it will be good to see you as well.
Okay, thank you. So I'm in a hotel, so I'll try to switch on my camera. I hope it works. Can you see the screen?
Yes, we can see the screen. We can see your presentation.
Okay, I'll just have a slide show.
Okay, we're seeing you now in slide mode, and I think we're seeing you on camera as well. So all set. Thank you very much, Sufang.
Okay.
Please go ahead.
Okay, good morning, colleagues. Very happy to join today's conference. This is annual conference, and thanks for inviting UNICEF to join this important conference and discussions. So I'm going to share with you UNICEF's perspective on South Africa's whether South Africa can achieve the SDG goals related to child health. Sorry, it's not moving. Okay, so I will touch base the progress of child health related SDG targets and the actions to accelerate the progress. So these slides shows the child mortalities starting from the stillbirth to neonates until the youth. Recently, our analysis included the youth at 20 to 24 years old. From here, you can clearly see that the child mortality, especially the postnatal that period, the mortality is highest, followed by the stillbirth and also the mortality during the youth period, and then the newborn period. So in terms of number of deaths, you can see every year South Africa has almost 26,000 post-neonatal deaths and also about 20,000 stillbirths. So this is a serious issues, and the percentage share you can see from here. So if we look at the trends of under 5 mortality, you can see within the recent decade, the under 5 mortality rate reduced is mostly due to the post-neonatal mortality reductions, but the neonatal mortality rate hasn't changed much. And this slide shows the mortality rate for children between 5 to 29 years old. You can see that the mortality rate during the youth at 20 to 24 years. This period, the mortality rate is high, and also within recent decade is reduced significantly. But the mortality rate during the older adolescents, which means the age between 15 to 19 years old, there's not much change. So what about the disparities? So these slides shows the ratio of under 5 mortality rate by poorest to richest. If you look at the trends from 1990 until 2020, there's the ratio of under 5 mortality rate by poorest to richest, no change. The poor families, their children have 2 times more likely to be died comparing with the rich families. So the disparities between poorest to richest are persistent. And so considering South Africa is upper middle income countries, so I compared the mortality rate among South Africa, other Eastern Southern Africa, global average, and also upper middle income countries and high income countries for stillbirth, neonatal mortality rate, under 5 mortality rate, and mortality rate at age 15 to 24 years. If maybe we can just zoom in the mortality rate for South Africa. This is a pink color, and also the green one, which is the mortality rate in upper middle income countries. No matter stillbirth or mortality, other child mortalities, South Africa is always 2 times or 3 times higher than the upper middle income country average. The maternal mortality rate is the same situation, which I'll not touch base this in today's presentations. So the assumption is the mortality rate reductions will be reduced. The speed of mortality rate reduction will be reduced because if the mortality rate already low, but when we compare the annual rate reduction between different countries, you can see the South Africa, the pink one, and also the green one is the upper middle income countries. Although upper middle income country, their mortality already low, already very low, but their annual rate reductions is much, much higher than South Africa. And what about the share of under 5 and the share of stillbirths in upper middle income countries? This is the share of mortality in Eastern Southern Africa regions. So there's almost no change in recent decade. But if you look at the share of stillbirths, the blue one, and also share of under 5 mortality, this green one. In recent years, the share has increased significantly. So we can't talk about malnutrition. So when we talk about the mortalities, this is the comparison of stillbirth, overweight, and wastings among South Africa and other groups. So let's just look at South Africa, the pink one, and the green one, the upper middle income countries. So our malnutrition rate is much higher than the upper middle income average. So regarding the coverage along the continuum of care, from the pre-pregnancy to pregnancy until birth, postnatal, infancy, and childhood, the coverage at some stage is high. You can see during the pregnancy, during the birth, but there's still lots room to improve in terms of the coverage, both pre-pregnancy and ANC4, and also the childhood intervention coverage. I didn't include the quality of care indicators. Definitely, that's also a big issue. So what's the progress on the SDG indicators, all the Every Newborn Action Plan (ENAP) indicators, which is stillbirth. So for the neonatal mortality rate and also post-neonatal mortality rate, if you look at the annual average annual rate reductions, so based on this, we can achieve the SDG target. In fact, we already achieved SDG target on neonatal mortality, and we are on track to achieve the SDG target for under 5. But I will mention that later, whether we need what we need to do and whether we are really on track. And for the stillbirth, that's the different scenario. So our current annual rate reduction is a 1.2, and we need to triple our effort in order to achieve the ENAP target on stillbirth. And the future we want by 2030. Here shows the projected mortality rate under different scenarios. If the mortality rate remain constant, the blue one, current trends maintained, the dark yellow one, and also the green one is the if we achieve the SDG target, and the light yellow one is the high income country average rate matched. So with these different scenarios, we can see that what's the situations for mortalities. So for adolescent, we don't have there is no SDG target. So here there's no bar at here. And how much deaths can prevent it if we achieve the different goals, or if we reach the different target. So these slides, the first part, the left-hand side, shows the projected deaths with under different scenarios. And then the right-hand side is a projected deaths prevented under different scenarios. So if we can achieve the SDG target, then 11,000 children under 5 deaths will be prevented. And if we achieve the stillbirth INAP target, 24,000 newborns will be prevented. The newborn or stillbirth deaths will be prevented. So here, I don't know whether I can, this link is work, is work. Just want to show you the UNICEF website, which has an assessment on the each country's SDG target. Here is the child-related SDG target. You can see the historical progress and the effort need to meet to the 2030 target. So the first part is the survive and the thrive. There's also other learnings. So I just want to show you. So here you can clearly see the standing target, historically very big progress, and really need very high effort in order to achieve the SDG target, same as the overweight. And then for let's look at the under 5 mortality. So probably historically the progress is average, and we still need high effort to achieve the under 5 mortality. Although, as I mentioned previously, based on our current trends, we can achieve the under 5 mortality rate. Given that uncertainty, and also the vaccine coverage still is not up to the levels. So that's why what UNICEF assessment is under 5 mortality rate. We still need high effort in order to achieve the target. So back to my presentation. So to summary of the epidemiological situation, accelerated effort required to achieve stillbirth target and also the under 5 target. And
Sufang, we have 2 more minutes.
Okay, we have a persistent disparities in child mortality and a high mortality rate and a low annual rate reduction comparing with upper middle income countries, and the low coverage for postnatal and childhood interventions. Of course, quality of care is also need to consider, which is compounded by 5 C's: COVID, climate, cost of living, crime, and complexity. So what to do? How to accelerate focus? We really need to be focused to prioritize the province, the districts with high mortality, with high number of mortality, and also focus on the pools. And the subnational focus is also critical to have a subnational plan data, and also the support local implementations and improve the efficiencies. So besides the health systems, we also need to think about the other sectors like food system, child protection, education, and the social protection systems, and also considering the community engagement and the social accountabilities. So as for the stillbirths, at least 2/3 of stillbirths happened during antepartum. This is the global data set. So what we need to do, where we should focus in order to reduce stillbirths, so you can get answer from these slides. Besides, we really need to think about considering survive, not only using the evidence-based interventions, but to make sure the evidence-based interventions can be implemented locally, and also considering family-centered developmental supportive care, and also reducing the barrier discriminations so that children can survive, thrive, and transform. So to summarize my key message, efforts need to make to reduce stillbirth, child mortality. We need to use a multi-system approach to reduce mortality to meet the SDG target. And we need better prioritization and improving the efficiencies, and shifting from access and coverage to equitable coverage with quality, and moving beyond the survive to survive, thrive, and transform. Subnational focus is critical to accelerate progress, and we need to integrate quality of care at every step. Thank you so much.
Thank you very much, Sufang. I think you've created the landscape of what this conference is all about. You've shown us some of the global SDGs. You've given us a wonderful introduction to what the situation is in South Africa. And many of our speakers will now be homing in on those individual ones in the next hour. But I think we've got a very good idea of what needs to be done, but also the UNICEF approach of how one tackles these different indicators that need achievement. So Sufang, thank you very much. We'll take further questions during the panel discussion, which you'll join, but very much appreciate your attendance at our opening ceremony. So perhaps I'll now ask Ute to take us through the next bit of our morning session. Ute, over to you.
Yes, thank you very much. And thank you for that fantastic opening session, which really gets us going on to our next bit. As Haroon has indicated, will now be unpacking the various bits and pieces. And we have a fantastic lineup of speakers. I'll keep the introductions for everybody short, because everybody's just got 10 minutes. We gave them the very impossible task to summarize their topic in 10 minutes. But the idea is really then to afterwards have time for discussions. So we're going to start off with Professor Fawcus, from an obstetrician and gynecologist from the Western Cape, who I think needs no introduction. So thank you, Stu. If you can start sharing your slides. So this her topic is on the maternal mortality piece. Yes, we can see your slides. If we can just go onto slide view. Yeah, that's perfect. Although you're on the second slide now.
Okay, thank you.
Yes,
and
good.
Can everyone see and hear me? Yes.
Okay. Yes, all good.
Thank you. Yeah, thanks very much for inviting an obstetrician to your child health meeting. But I'm going to be talking about the maternal health, and obviously maternal health is absolutely vital for the survival of the child. The data I'm going to be presented is from the South African Confidential Inquiry into Maternal Deaths. So looking at how we're doing in terms of going towards the SDG by 2030, this is the number of maternal deaths from 1998. And maternal deaths, I just need to remind you, are any death of a woman during pregnancy, during childbirth and up to 6 weeks afterwards, and they exclude what we call coincidental if a pregnant woman dies in a traffic accident. So they're related to pregnancy either directly or indirectly. And you can see after the inquiry started, everything unfortunately increased. It was the effect of the HIV epidemic, and there was a maximum number of deaths in 2009 where there was H1N1 and untreated HIV for the mother. Treatment of the mother came later than treatment to prevent PMT-CT. And then it came sharply down, and then there was a big sort of blip in 2020, 2021, and that was, as you all know, from COVID. And if we look at maternal mortality ratio, which is the thing that we're measuring for the SDG, we want by 2030 to have a rate of 70, which is actually off this chart because it's lower, maternal deaths per 100,000 live births. And again, when we, in 2016, we set a target by 2020 of having an MMR of less than 100 in South Africa. And we actually got there in 2019. It was 98.8, and then went up again, as you can see, 20 and much more in 2021, which was when the COVID pandemic was at its worst. But then reassuringly has started to come down. So it's like as though we've lost 2 years in terms of a trajectory, but it looks as though we are hopefully on a downward trajectory. Now, we often look at maternal mortality in 3-year sections, so because you get more data, and this again from 1999 showing the same rise to 2009 and decrease, and this was really the advent of ARVs and other programs on direct obstetric deaths. This line here is our target. This is our 70 that we want to achieve by 2030. And again, when you look at 3-yearly data, you see it went up again in the last triennium. And if you compare provinces, which is very important, on the right-hand side, you can see the South Africa as a whole, but nearly every province over the triennia from 2011, we had this steady decline and then an increase in the last triennium, mainly because of the increase in 2020 and 2021. The Western Cape has actually always achieved 70, but in the last triennium it exceeded. And there are other provinces which have shown remarkable progress, like KwaZulu-Natal and even Limpopo, which used to have the highest maternal mortality of all in South Africa, has shown a steady decline, actually even declined in the last triennium. I think the inequity between provinces is something that has to be tackled. It is not appropriate that you have a higher chance of maternal survival if you live in the Western Cape than, say, in the Free State. Obviously, what is causing all this, the maternal deaths, is the most important thing. It's a busy slide, but down here gives you the conditions that are our worries, and I've put in bold the most common ones. And these are the different years, and this is the triennium. And always our biggest cause of maternal death is non-pregnancy related infections. And up to now, it's nearly always been the HIV, TB problem. And this is the group that came down. Now in the 2020 and 2021, COVID dominated. Here there were 124 COVID pneumonia deaths, and here 369. But by 2020, there was only 12. So the effect of the COVID pandemic upped this group enormously. Of note, and almost a surprise, was this increase in obstetric hemorrhage during these 2 years of the peak of the pandemic. And we think this really is illustrative of the fact that the COVID pandemic affect the function of the health system. And of all conditions, obstetric hemorrhage, postpartum hemorrhage needs your system to work. It needs your transport, your staff. It needs people available to monitor. And I think this is indirectly showing, as perhaps the slight increase in hypertension and medical disorders, how the pandemic affected other conditions and mortality. So these are our main causes of maternal death. This group: hemorrhage, hypertension, medical and surgical, mainly cardiac. This is looking at trends over time, going back to 1999. And this is the non-pregnancy related infection group that showed this big sort of peak there, came right down, went up in the last triennium. Hypertension slowly coming down. Hemorrhage maybe not coming down quite so quickly and going up again in the last triennium. The medical and surgical disorders showed a jump in 2008, and that was because we actually changed, we became more inclusive and included suicide, psychiatric disorders as maternal deaths in line with the rest of the world. We're a bit worried about early pregnancy problems. We feel this could be a bit neglected. In terms of where the deaths happen of mothers, and I would have to say that our confidential inquiry probably misses some home deaths. I think the reporting is predominantly facility, although we do hear of deaths outside facilities from forensic pathologists and also by word of mouth. But I think this is definitely underreported. Women who probably deliver in a facility, because we have a high facility delivery rate, but then maybe die in the first week, having been discharged from hospital after 6 hours. Of note, some women die on the way. This is in an ambulance between, and this would be mainly the hemorrhage deaths. And this gives you a breakdown of where the women die. Now, obviously, many women the majority of women will access a CHC, but they'll be referred on. And so referral patterns play a part in the location of the death within the public sector. In the last triennium, there were more deaths than usual in the private sector, again, another effect of the pandemic. This is a busy slide, but the unique feature of the confidential inquiry is an independent expert assessment of why the woman died, looking not only at the cause of death, but whether there were factors within the health system that were suboptimal and contributed to her death. And these are the 4 groups of suboptimal care. And these 2, suboptimal care possibly impacted on outcome, or probably, we add together to say this percentage was potentially avoidable. And in previous years, it's been over 60%. It was slightly less in the last 3 years. And I think it was perhaps because people were thinking that the COVID deaths weren't avoidable. We also break the preventability down. The factors at patient community level, we don't explore well enough. And this is a defect in our system. We had expected that during the pandemic, women might not come for antenatal care or delay coming for care, but that we were proved wrong. Women continued to come for antenatal care. And I think one must get away from the concept that, you know, mothers come late or mothers don't come, because I think mothers do all they can to do everything for the baby in utero. Administrative, this is health system factors, are usually in about 50% of our maternal deaths. And it was particularly more in the bad years of the COVID pandemic. And we know the impact it had in terms of health staffing levels, transport, etc. In terms of healthcare provider avoidable factors, it varies slightly between level of care, but in the last report and previous ones, we've always kind of rather pinpointed the district hospital, which bears a huge burden of work and often unpredicted sick patients. This is looking at avoidable deaths. Yes?
1 minute, sorry. Yes?
How much? 2.
1 to 2, yes.
I wanted to, okay. Just showing that the most avoidable deaths are the hemorrhage and hypertension deaths. And that in terms of level of care, again, the district hospital. And in the interest of time, I'm not going to summarize the data. I'm just going to go on to my last slide, which is, what needs to be done. And our framework, which we've had for a long time, focused
Have we lost Sue now?
Yes, it seems like it.
Sue, are you there?
you muted? Sorry, I think I might have muted myself.
That's
Can you
fine.
hear me now?
Yes, we can. Do you want to just say like 2 or 3 sentences summary?
Okay, so this is our approach to what needs to be done, and what I've highlighted in yellow are the sort of, if you like, low-hanging fruit at the moment, introducing e-motive for postpartum hemorrhage, focusing on early pregnancy. In red, I think, are the biggest reasons why we might not achieve our goal is unless there's improvements in clinical governance and leadership. And perhaps the biggest obstacle is going to be this austerity budgeting at the moment. And it's going to be quite difficult to improve things while this is happening. Just one other thing in terms of anemia, I'd just like to look at pre-pregnancy. We are now seeing that anemia is actually at the root of many of our maternal health problems. And we think that is another sort of low-hanging fruit where we should focus. So thank you very much. I'm sorry I muted myself for a few minutes. Thank you.
That's fine. Thank you very much. That was fantastic. We'll move over to Professor Haroon Saloojee, who you've already met this morning. So he's a child health specialist from Johannesburg, and he will be talking about perinatal and neonatal mortality. Over to you, Haroon.
Thank you very much, Ute. So I'm going to be covering the arena of neonatal and perinatal mortality and answer 6 questions in the 10 minutes that's been given to me. I'll probably do a very superficial job, but I'll certainly try. So the 6 questions are, firstly, why has South Africa's neonatal mortality rate hardly budged over the last 2 decades? While we've had reductions in under 5 and infant mortality, we haven't seen the same for neonatal mortality. Why is that the case? What can we do right now to change the momentum? Where do I think, or where should we be by 2030 when the SDGs expire? What will need to happen to get what do we need to do differently? And then if the issue is particularly equality and equity, where do we, what needs to happen? So that's quite a tall order for 10 minutes, but let me have a go. I think most of us are aware of the SDGs, the 17 SDGs, and where we'll be spending most of this session is SDG Goal 3, and more specifically Goal 3.2, which I'll be looking at neonatal mortality. The target, as I think most people know, is that all countries will have to reach a figure of 12 per thousand. So unlike the MDGs, where it was proportional reductions, 2/3, 3/4, here there's a single absolute number. If one looks at the history of it, there has been some success between 1990 and 27, about a halving of the neonatal mortality rate, which equates to about 2.5 million newborns being saved over that period. However, there is this global inequity where the highest rates are around 44 per thousand, and the countries with the best neonatal mortality rate are actually below 1 per thousand. So there's quite a vast difference internationally. And where does this difference lie? So the green areas are the ones where the neonatal, the SDG target has already been reached. And you can see that covers many parts of the high-income countries. But it's Africa and some parts of Asia that's the problem. And perhaps the fact that very few people know is that which country has the worst neonatal mortality rate in the world? And it came to me as both a surprise and a shock that it's actually our neighbor Lesotho. So I've often asked, why aren't we doing more about the situation right next door to us? Now, this is a chart that I think many of us have seen over the years. This is the data showing what's happened in these rates over the period from 2000 to 2020. And I think what's clear is while we've managed to reduce both under 5 and infant mortality, it's that one at the bottom, the neonatal mortality rate, which is really the one that's of most concern. That you can see over the last decade, it's effectively a straight line. If you go to a little bit more granular detail, these are the numbers. And again, looking at this last row, this is showing data from 2014 to 20, the number remains at 12. Now, there's even arguments of whether our rate is really 12, because a lot of this data is based on DHIS data, which we know is public data. But data from surveys like the South African Demographic Survey and from individual surveillance sites or demographic sites around the country suggest it might be much higher. So the 2016 demographic household survey showed a figure of 21 per thousand. And many people believe that the 12 actually flatters. And there's reasons for that, including our poor data capturing systems, particularly poor capturing of deaths. I think Sue showed a figure earlier for maternal mortality. We see the same reflected in neonatal mortality, and you would see this for other mortalities as well, where with the Western Cape having the best outcomes, and places like the Free State and Northern Cape having much beyond the national average. And this is a manifestation of the inequities in the country. But let me show you this data is that probably not well known among many of us. So we have about 1 million deaths in South Africa each year. And where do these, 1 million births in South Africa each year. And where do they occur? Well, let's just look at the 2018 data. So not surprisingly, almost half happen at district hospitals, and probably another 300,000 happen at regional hospitals. If you look at the deaths, again, not surprisingly, you would expect then most deaths to happen at district and regional hospitals. But this is the data that I really want to share. This is the neonatal mortality rate. So one would expect this increase as one gets to higher levels because of referrals. But for me, it's this area where most of our attention has to be. District hospital, regional hospital, having these, what I would consider very high neonatal mortality rates, 9 and 11 per thousand respectively. And I think that this figure highlights for us that we know where most births are occurring, but it's also where our majority of attention has to be. And then something that we don't focus on much, certainly as child health practitioners, is the stillbirth rate. And we've seen this number. Now, again, there's a lot of lines here, but the bottom line we heard from Sufang's earlier presentation is that the stillbirth rate in South Africa is 16.2 per thousand in the latest figures, which is actually higher than the neonatal mortality rate. So we lose more fetuses as stillbirths than we use neonatal mortality. And certainly in this country and in most countries around the world, there isn't enough attention on stillbirths. Of course, we put the responsibility on our obstetric colleagues, but I think this is a cause of distress for us, and as child health practitioners, we should be focusing on this as well. Okay, moving on then to what are the causes of neonatal deaths. Again, this is probably known to many of us. This data mostly, again, comes from the Perinatal Problem Identification Program, but not surprisingly, about half of all neonatal deaths are prem, perhaps a quarter are asphyxia-related or intrapartum-related injuries, and then you can see the other quarter includes congenital abnormalities and infections. But this doesn't quite give us the true picture, because it's this infection figure, which often in data comes from the first 7 days and doesn't completely capture the influence of infection. Here's some alternate data that comes from Soweto, where every neonatal death of a period had minimal invasive tissue sampling, including cultures of sites, the lungs, sometimes the brain, and also of blood using more sophisticated technique. And the results shouldn't surprise us. That suggests that 58% of all neonatal deaths have an underlying infection, and that increases to 72% in preterm babies. So a lot of preterm babies are dying. Maybe we call it a preterm death, but in fact, the underlying cause is infection. Worse still is what are the infections that are causing it? And it doesn't matter where you are in the country, whether you're in a central hospital, tertiary hospital, or we know whether you're in a district or regional hospital, it's these horrible bugs like Acinetobacter, Klebsiella pneumonia, and Staph aureus that are the major contributors, particularly Acinetobacter and Klebsiella. So that's where our problem lies. This doesn't surprise us. So this is problem PIP data, which suggests what are the modifiable factors. We'll learn a little bit more about them. But let's just look at the top 3. So clearly infection comes through even in a PIP analysis. The number 1 comes through as inadequate facilities, equipment in natal nursery. And clearly this mostly affects our preterm infants. And then number 3 is fetal distress and fetus not monitored, which is the asphyxia component of it. So we know this. Here's some data that supports it. Let's get on to, so what do we do with the fix? I've got 2 minutes left, and here's a big Lancet paper, but the analysis is both global and in South Africa. That probably, it's the poor quality care, which is the fundamental issue. And in fact, that's my answer to the question, why have under 5 and infant rates come down, but not neonatal? And I would argue that for both under 5 and infants, we had some magic bullets. We had antiretroviral therapy. We had the vaccines like pneumococcus and rotavirus, which were able to reduce pneumonia and diarrhea deaths, and perhaps even some of the socioeconomic improvement over the last decade. But for neonatal mortality, it's basic healthcare that's the key. There's no magic bullets. There's no drugs or vaccines. And I think that's been our inability to provide that. That has been the major reason we've stagnated at the number 12. It's not for lack of trying. Here's a long list of interventions at the national level, from re-engineering of primary health care to training programs, including helping babies breathe and ESMO-E. We've continued those modality audits with the PIP programs. And we've introduced a lot of interventions in the last decade, including more use of steroids. We've got CPAP coming into many of our regional and district hospitals, and even KMC has expanded. But clearly, all of these interventions haven't quite made a difference. So what is the solution? And so in the last minute, the answer seems to be, from the literature, what's called structural reforms. Now, what the heck is structural reforms? It's about improving service quality, and 4 key factors have come up. It's about governance, it's about leadership, it's about getting our service delivery better, and getting the community to demand quality services. None of this comes as surprises to us. We've known about this. In fact, if you look at the South African health policy, the maternal perinatal, I'm sure not too many people have looked at this document. But if you look at the objectives, it actually says all those things are important. What we don't know is, we can say these things, but we don't know what activities are required. And so I hope that in the discussion that we will have, the group discussion, I'll be able to give you some ideas of what I think are the priorities. But my time's now up, but perhaps the 3 things I will focus on, just to highlight, is that the idea of an essential package of newborn care, the issue of within our services reallocating resources, both space and staff for neonatal care, and also what we should prioritize within neonatal care. And here are my suggestions for that. There are many ideas about what the neonatal mortality is going to be by 2030 at a global level, lots of modeling, lots of scenarios. Where are we going to be? Well, everything predicts that it's going to be 12 again, because that's unless we do something differently. But I'm really hoping that when I come to the 2031 Child Priorities Conference, someone's going to show this slide, which says that the neonatal mortality rate was 6 in 2030. And if you look at the cause of deaths, that's what it looks like in Ireland. And it's going to be very similar to that what we're seeing. This is obviously my dream, but I would hope that the interventions we're going to talk about might make the difference. Thank you very much.
Thank you, Haroon, for a fantastic presentation, and also to help us start dreaming. I think that's really important. The question is how we're going to get there. So thank you very much. We will now move on to child health. Under 5 mortality. So Prof. Neil McKerrow is child health specialist from KZN. Neil, if you want to start sharing your slides along. Yes, can see it. You can just go into presentation mode. Yes, that is perfect. Thank you, Neil. Your 10 minutes are starting now. Thank you.
Right. Thanks, Ute, and good morning, everybody. As to be expected, there will be a little bit of overlap, but I have not been nearly as innovative as Haroon, so just bear with me and see what I have to say. With respect to child health, we have no recent latest data. You know, Stats SA is our primary source of data. It gives a picture of what is happening within the health sector, outside the health sector, the public sector and the private sector. But we've had no access to Stats SA data since 2018. So to get a picture of what's happening in terms of under 5 mortality, we really need to look at projections and what the estimates are from the global level. And there are 3 big estimates that are available. The United Nations Interagency Group on Mortality Estimates, the Medical Research Council here in South Africa, and Stats SA doesn't release mortality data, but they do talk about mortality when they look at population growth. And you will see that the under 5 mortality is fluctuating somewhere in the range of 28 to 33 deaths before the age of 5 for every 1,000 babies born in the country, and the infant mortality rate, which is part of the mortality, ranges from 21 to 26 deaths per 1,000 live births. Looking at where we've come from, what you'll find is the Stats SA data shows exactly what's already.
Neil, we're having some difficulty with your... Neil, we're having some difficulty. Perhaps you want to put off your video and we'll just stay with the audio.
In the early part of the century, and from 1990 to about 2002, the rapid growth of faculty developed by the HIV/AIDS epidemic, a number of vaccines, right. So
Neil, we've had some difficulty hearing you.
The image on your right.
Can you perhaps put off your video?
Okay, have we lost him now completely? Neil, are you still there?
Neil, I think you're muted. Just check your sound.
Neil, can you hear us? We can't hear you if you are trying to talk to us.
I'm here. Can you hear me?
Your sound is, it's quite bad.
Yeah. We have a power failure and a storm in Hilton at the moment. Can you hear me at all?
Okay, so it's better now. So let's try it again. Yeah, that's fine. Please go ahead.
Okay. So sorry about that. I'm not sure where you lost me, so let me just start at the beginning. The Stats SA data really shows that from 1990 until the early part of this century, under 5 mortality was increased. It plateaued out around about 2002, and from 2007 it starts in a number of vaccines, particularly pneumococcal and rotavirus vaccine. If you look at the picture on the right, the MRC data shows exactly the same trend with a decline in under 5 mortality from about 2007, 2006. And what I want you to note here is the narrowing in the gap between your infant and under 5 mortality and the narrowing in the gap between the infant and neonatal mortality. So the MRC data suggests that the greatest decline occurred in the age group 1 month to 1 year. However, we'll come back to that when we look at the UNICEF data. If we look at the rate of reduction, Sufang has shown some of this, but based on the UNICEF data, from 1990 to 2021, there was an annual rate of reduction in under 5 mortality of 2.1. But this includes the increase from 1990 to the early part of this century. So if we look at later periods, you will see an annual rate of reduction from 2000 until the present period of 3.7, 3.8 per annum. But from 2015, the rate of reduction dropped slightly. So using those annual rates of reduction, you will see the image on the right. The red line is the SDG target of 25 deaths per 1,000 births, and the under 5 mortality reduction of 2.1 from 1990. If that was the projection, we would not reach our Millennium Development Goals. But if we use the more recent 3.5, 3.7 annual rate of reduction, we will just sneak in and achieve the Sustainable Development Goal by 2030. Now, when we look at these deaths, you will see, starting really from the fourth column, which is the 1 to 11 months, you will see there's been a 22% reduction in mortality in the age group 1 to 11 months, virtually no reduction in the 1 to 5-year age group, and an actual increase in the number of deaths in the neonatal period 0 to 28 days. And as a result of this, when we look at the proportion of under 5 deaths, the proportion attributed to our older children, 1 to 4 years, remains constant. The proportion due to infants, 1 to 11 months, has actually dropped. And the proportion due to neonates has actually risen. So our successes have been in the infant period, and our problem remains the neonatal period. When we look at the causes of death, the 3 big overarching groups in cause of death are communicable, maternal, perinatal, and nutritional causes, which are the blue, non-communicable diseases, which are orange, and then injuries, which are gray. And you will see over the past 20-odd years, there's been a sustained improvement in the proportion of deaths attributed to communicable, perinatal, and nutritional conditions, and understandably then an increase in the proportion of deaths due to non-communicable diseases. Looking at slightly more granular data, you will see a dramatic decline in infectious diseases in general, and some improvement in respiratory infections. Deaths due to neonatal conditions have actually remained pretty constant, and deaths due to nutrition have fluctuated a little bit because in 2019, there was a decline, but following the COVID pandemic in 2020, there has been an increase in nutritional related deaths. Now, the non-communicable diseases are slowly creeping up, and in non-communicable diseases, what is emerging is a greater proportion of deaths due to congenital disorders, and accidents remain a significant contribution, although accidents are a contribution to deaths primarily in the 1 to 4-year age group, where they contribute around 23% of deaths for that age group. So what we've seen over the past 2 decades or so is great improvements in the 1 to 11-month age group, great improvements with communicable diseases, and this relates largely to the introduction of vaccines, the introduction of antiretroviral therapies, and a shift in the epidemiological burden of disease. And we're seeing the emergence of congenital disorders, which now account for almost 9% of under 5 deaths. We're seeing a persistence of non-natural deaths, which also account for about close to 9% of under 5 deaths, and minimal change in the contribution of neonatal disorders, which is around 30% of our deaths. And there is a fluctuation in the contribution of nutritional disorders. In response to this, what we really need, if we are to achieve the Sustainable Development Goals, is we need to maintain current child health programs and services. The programs we've got seem to be appropriate. The implementation of these programs may be weak, but we need to maintain rather than look for alternative golden bullets. And what this entails is persist with our preventative and promotive programs, our EPI schedule, our vitamin A supplementation, etc. Continue with IMCI as the mainstay for the care of the sick child. Introduce ETAT more widely for the care of the ill child on arrival in our health facilities. So we need to strengthen the implementation of the WHO steps for the management of severe acute malnutrition, or whatever local variations have been adopted by different provinces. We need to strengthen our focus on neonatal survival, but Haroon has spoken to that, so I won't. We also need to implement the National Genetic Services Plan. This plan was adopted in 2020. It follows the life course process and really starts providing effective guidance in what to do about congenital disorders with 4 very simple interventions, 3 of which are immediately achievable: a comprehensive assessment of newborns before discharge, looking for structural anomalies, pulse oximetry to identify critical congenital cardiac disease, and screening of hearing. The 4th step, which is biochemical screening for metabolic disorders, is not yet feasible in our context. And finally, we need to develop a strategy for the prevention of non-natural deaths, and this really needs to start with creating a safe home environment for children, and this will contribute to a reduction in deaths due to poisonings, drownings, and births. So, in conclusion, we appear to be on track to meet the Sustainable Development Goals, but we can't relax and assume we will get there. To do so, we need to preserve resources for child health services, and we cannot re-experience what happened in the COVID pandemic, where resources were withdrawn and reallocated to deal with COVID. We then need, with these resources, need to strengthen and complement existing services and not try and identify any golden bullet. Thank you very much. Back to you, Ute.
Thank you, Neil, and thank you. We could hear you well in the second try, so that was perfect. For the audience, you can start typing in your questions in the Q&A, because after this we will have an audience interaction session in which you can either then ask live questions to the speakers, or you can type your questions in the Q&A. So over to Dr. Mandy Wessels, pediatrician from KZN, who will be talking to us about modifiable factors as per the ChildPIP program. Over to you, Mandy.
Thank you, Ute, and thank you, Neil. Good morning, everybody. So I think Haroon already mentioned quite a formidable task in 10 minutes, looking at all of this data. So I've chosen to focus on just 10 years of data, of modifiable factor data. And for those who are not very familiar with the program, remember that our modifiable factors come from the death data capture sheets, which are the final product of an in-depth analysis of every child that dies in a facility. The modifiable factors each have a code, which then makes it very easy to analyze in a database. And we analyze our modifiable factors in 5 categories, 5 categories of where they occurred and 3 categories of whom we think was largely responsible for either what went wrong or who could improve it for the future. So how it's divided is like this. Down the left-hand side, where do we think the modifiable factor occurred in our system, starting at the home and ending in our facility in the ward where the child died? And then the 3 categories are personnel, administrators, and family caregiver. Because most of us today are either clinical personnel or administrators, I'm going to try to focus on the codes that came up for us, but there are some family caregiver ones that can't be ignored because they talk to access. So I'm going to today, in our short time, look at the 10-year look back. So from January 2013 to the end of 2022, it's important to know that ChildPIP was excited to launch version 4 this year, but I've chosen to only include version 3.1 because in some provinces, version 4 has been a struggle, and that will be very patchy in representation. So in total, I'll be analyzing 158,000 modifiable factors. I have analyzed, and I will be sharing some of these analytics with you over the 10-year period. I'm going to talk quickly about overall how is the usage pattern of the modifiable factors in ChildPIP. Then I will just give you a very quick top 10 of the 10 years, the top 10 coded modifiable factors. I will look at avoidability overall in the system. And then what's really important is the trends. So this is something that Neil, our previous speaker, mentioned repeatedly over the years in his talks, was that it's not relevant necessarily looking just at the modifiable factor per death, but as an administrator, you need to look at the trends. What are we coding more often as a red flag of something we need to fix? And if things have been coded the same for 10 years, then it means we haven't actually addressed the glitch in the system that is leading to that modifiable factor coming up so frequently. So I thought a 10-year time trend would be important. And then if I have time, but I don't think I will delve into the free text modifiable factors, which I'll explain when we get there. It's the very first time that we as ChildPIP have ever gone into depth and looked at these. So just over the 10 years, what you'll see is that the total number of modifiable factors that have entered the database have decreased over time. So there's obviously two reasons for that. Number one is that the number of deaths, which is yellow, the number of audited deaths decreased at the same time period, but also there was a decreased uptake of CHIP in some of our hospitals over that time. And during COVID particularly, we lost a lot of hospitals in terms of their data capture, as data capture staff were reallocated to capture COVID vaccine and COVID data. But what's more important to look at is the green line, which is the number of modifiable factors that we coded per death. And you can see that even that has declined. So there are two, well, many more actually, but two big possibilities. The one is that our health clinicians are getting lazier, is a terrible word, but perhaps we don't look as in depth as we used to try and look at every possible modifiable factor. Perhaps we all have stopped trying to come up with 3 or 4 and just sort of said, these were the top 2 per death. We still have about 2.5 to 3 modifiable factors per death, which is pretty good. Or it is possibly talking to what Neil mentioned, is this rise in congenital abnormalities in our death data pool where we feel it's unavoidable. And so maybe the modifiable factors are not as readily available for those cases. So the top 10 over 10 years, interesting that 6 of these over the top 10 years were caregiver related. And if you add together caregiver delayed seeking care, caregiver did not recognize danger signs, the traditional remedies that come up in 2 of these top 10, if you add them together, it talks to the fact that 30% of our modifiable factors talk to the delayed access in the system, whether it's because the caregiver chose to go the traditional route first, or whether it's just that they didn't recognize the danger. Overall, in the last 10 years, 30% of our modifiable factors talk to delayed entry into the system. And as much as we calling it a caregiver factor, that does talk to us about access. Why do our caregivers think that their traditional healers are more accessible, even at that expense, compared with coming into our system? So something to think about. The top 10 clinical personnel factors over 10 years, there were 3 that were related to danger signs. So the inadequate recognition of danger signs, and then the response to those danger signs, and the severity of condition incorrectly assessed. And I think that really talks to our team that are driving ETAT and IMCI in terms of our programs. And we know ETAT went through a lull and is now being rejuvenated. So hopefully, if we do this exercise again, we can see that those are coming down in frequency. And then the top 10 administrative factors over 10 years, for those of us who are here from the National Department, is this high care and ICU, lack of beds at the own facility or the higher, is very prominent. 15.5% of our deaths had of our modifiable factors were related to higher care beds. And if you add the others slightly higher up, it's about 18% of our modifiable factors in total, where that clinicians felt there were not adequate numbers of high care and ICU beds. So the last one I've left there at the top is the inadequate transport and delayed arrival of ambulances. And this one I might not get to, but we are seeing an increasing number of deaths where this is coded as a problem. I'm going to skip over avoidability because it hasn't changed much, except to say that over the 10 years, we decreasingly say that we're not sure. And we increasingly say that there was no avoidability in the system. And again, that could talk to this number of rather unavoidable congenital abnormality, expected deaths in our system. The yeses haven't changed much. And then if you look at the where, it's interesting. At the start of ChildPIP, we tended to allocate the caregiver and the home as a very prominent factor. And then we changed the way the codes were published, where we put the ward first. And that then made our factors in hospital go up in number. And now if you go back again the last 10 years, you'll see that the caregiver and the home percentage are rising again, while the clinical personnel factors have actually come down again. I'm not sure exactly what it means, but it's something to watch over time. So talking to what I said that Neil used to mention a lot was rather looking at the trend. So I've actually just chosen the ward and the clinical personnel, and I looked through all, I don't know how many there were of each of these, but thousands and thousands of them. And I looked to see where there were significant trends. So concerning trends is that the lack of high care ICU facilities for children are on an increasing trend. We are coding that more often than we used to over the last 10 years. An inadequate number of doctors assigned to children's ward has come up in number. That may have been COVID related. And then the inadequate response to new danger signs again is climbing, and could talk to the fact that we had a lull in ETAT training over the years. But on the flip side, encouraging trends were that we less often code the lack of a pulse oximeter. We less often seem to think that there's inadequate nurses. Our record keeping seems to be getting better in our deaths, or we're not coding it as often. And the WHO 10 steps are decreasingly coded in SAM deaths. And then our general charting, input, output, adequate history taking and investigations seems to be allocated less often as a problem in the children who die. So that's in the wards. And if you look at the clinical personnel, the concerning trends again are the inadequate response to the new danger signs at the clinic, and the inadequate fluid management with diarrheal disease, and then the severity of the child's condition incorrectly assessed. So again, it's a concern for us in ChildPIP and to the ministerial committees, I'm sure, that we seem to be coding these codes more often than we did at the start of the 10-year period. And then again, on the encouraging trends, the bulk of these relate to HIV. And I am scared to say that I think we might see a difference in this again. We know that our HIV programs seem to have been slightly uncoupled over the COVID time period, and we are seeing again results not chased and ARV referral not necessarily happening on time. So we'll watch again in the next 5 years how that changes. But for now, over the 10-year period, the HIV services seem to improve and contribute less to death, and the same with the severe malnutrition. So those were the encouraging and the concerning trends of just 2 areas that I analyzed. If I do have time to quickly do just the 2 slides on the free text, it's the first
1
time.
minute.
1 minute.
Yes.
Maybe I must then skip it. Or let me just say this.
No, it's fine.
We analyzed for the first time the ability of our doctors or our clinicians to type in free text into their modifiable factors. And I went just to dig in there to see what makes us feel passionate enough on the modifiable factors that we feel we need to go and add extra typing into the database. So I just had a quick look at this. Unfortunately, there were 22,800 of these free text modifiable factors. So they were difficult to analyze, but quite interesting. And I just quickly summarize them. Obviously, the bulk of these are the HFO, the CPO, the other factors, and where you are forced to add what the other was. But when I looked at these in depth, actually most of them were codes that could have been found elsewhere. And I think that's where people didn't feel like reading the 5 pages of modifiable factors, and they put other and then wrote the other, and that actually there were codes for those things. And then I found it interesting that there was a lot of codes relating to IMCI where free text was added. And I think that's because I think there was something like 3,000 or 4,000 of these where people added in which part of the IMCI guideline wasn't followed, which was really interesting and could be studied on its own. And the same with traditional medicine use. 600 free text codes were related to traditional medicine. And there, I think it was people explaining, had an enema first, went to traditional healer first, and what they took. There was some description there, again, something that could be studied separately. And then the HIV, SAM, and diarrheal disease interesting that people felt the need to add, like the inadequate quantity or quality of food wasn't just left there. People added, porridge was given at 2 months, for example, or in the HIV, they would say, caregiver didn't decline the test, but they were in denial, and they tried to add more detail. So it feels like with those 3 priority areas, HIV, SAM, and diarrheal disease, the healthcare workers coding the deaths felt passionate to add some extra into their modifiable factors. And it's quite a fun thing we can unpack when I have more time, sometime at another talk. I think I'll leave the recommendations, Ute, for our panel discussion. It makes more sense when we come back to summarize at the end. So I will leave you with that. Thanks very much.
Yes, great. Thank you very much. That was very interesting. I hope everybody head is still on the right place and not spinning, because we've had a lot of information, but really very nice to see these talks, one after the other. And the engagement will follow after Tony's talk now. So Professor Tony Westwood is from the Western Cape and will be talking on child morbidity. So over to you. Thank you, Tony.
It's a pleasure. I just want to hear that you can see a slide and you can hear me.
Yes, both.
Okay.
Yes to both.
So a change of tack, and welcome. Thank you very much for inviting me to do this talk. When it comes to morbidity, there are a lot more conditions and a very much wider canvas than we've been discussing so far. And morbidity, we need to consider, what is morbidity? Well, it's the presence of disease, but I don't want us to think about misery when we think about morbidity, because there are factors in people's lives that can allow for resilience and for good quality of life in the presence of morbidity. So I've been asked to look at what's happening now and what might happen in the future, and not confined by the MDG period. So I've been a bit idiosyncratic here, both in my choices of things in the large scope of things to talk about in child morbidity. And here's my classification, which you can make your own one. Here they are, and they'll come back later, so you don't need to memorize these now, and I'm going to go straight on. But all the things that cause morbidity or prevent morbidity have M words, modifiers, either multipliers or mitigators of morbidity or its severity. So where are we in 2023? Where were we in 2003? And I want to look at what we did in 20 years that we might take a few lessons for the next 20 years. And where will we be in 2043? Well, I don't know where I'll be. So where are we in 2023? So here we are with psychobehavioral morbidity. And what may surprise people in the very first line is that our children really think of themselves as being pretty well psychologically, 86%. Now, this could be just to keep themselves feeling well and not to go down and feel unwell. But more objectively, psychological well-being is 86%, which does mean that 46% are not feeling that way. When that's unpacked, you find that, which is the next 2 bullets, you find that there's a considerable amount of anxiety and other things that are going on in children's lives, which may or may not cause morbidity, but are risk factors for long-term or short-term morbidity. And we'll move down to the 4th, which is depression among adolescents. We don't have a lot of data on this, but about 10% in rural and about 15% in urban. The more older you get, the more this becomes part of it. When we look at neurobehavioral, we have very patchy data, as many people will know, and we seem to have a rising numbers of ADHD, autistic spectrum disorders, and ID has been sitting for in intellectual disabilities, been sitting for quite a while, wherever it is. Pre and perinatal morbidity. So this includes congenital anomalies. Low birth weight sits at about 13%, varying from 10% to 18%, Northern Cape at 18%. And this, of course, is associated with, in many cases, with lifelong morbidity. Out of this comes cerebral palsy, as well as associated with asphyxia and congenital causes, sitting at the international figure of about 2 to 2.5 per 1,000 live births. Congenital anomalies, depending on where you look, you get those figures. And congenital heart anomalies at almost 1% of live births, and that is an international figure. And just to tell us, this is an area we particularly need to look for equity of access to care, because a lot of those are treatable in our current circumstances. Nutritional morbidity, and there's some things missing here that you might think, well, they should be here, but they're not here, but they'll come up somewhere else, and I'll tell you why. We've talked about stunting already, which is a significant morbidity, and of course it's not only a nutritional morbidity, but I had to put it somewhere. SAM incidence, that is 2% of all children having severe acute malnutrition under the age of 5, which is a lot of children. And this one that we still haven't tackled as a country, of anemia under 5 years of age. Look at those figures. This has major effects on quality of life and cognitive effects. So there's some areas we haven't even touched on morbidity. Environmental morbidity. Well, I'm going to put diarrhea in here, or you could call it an infective morbidity, but I'm going to call it an environmental morbidity. And we're sitting at an improved figure of 7.2 per thousand children under 5 years, and pneumonia at about 20 per thousand children under 5, or if we look at it another way, taking the Drakenstein study, 0.27 episodes per child year. So still significantly affecting children. Both of these, even one episode of either of those, can lead to long-term morbidity or susceptibility to other diseases and recurrence of those same diseases. Here's overweight and obese, which you wanted to be in nutrition. I've put them in environmental, and we can discuss that later. Figures of about 20% for urban and 16% for rural. That's the young ones under the age of 5, and the increasing chances that they will go on to be overweight and obese adolescents and adults. Poisoning, a significant environmental morbidity. This is the best that I could find. 108 per 100,000 children less than 14 years of age. And if you consider that we have about 20 million children in the country, that's a lot of poisoning that's getting to hospital, let alone what might be happening in the home. That's toxin ingestion. And then in environmental morbidity on violence, I've used the Optimus study figures for sexual abuse of a lifetime among children measured between the ages of 15 and 17, about 10% in boys and 14% in girls, which has a significant morbidity associated with it. And these children tend to have other forms of neglect and abuse as part of their life trajectory as well. Last group, no, it's not the last group, immunoinfective. Asthma is an immunological, very high rates, large amount of underdiagnosis in our country. Allergic rhinitis even higher. And then tuberculosis, we have that number. HIV infected, about 300,000 of them under 15 years, and about 1 in 4 children being HIV exposed uninfected, which has associated morbidities that we're still learning about and researching. And then I've just given one example of an immunological condition that's also often precipitated by infection, and that's diabetes mellitus, using African figures because we don't have our own, of somewhere about 800 per 100,000. So significant numbers if you were to multiply that by the number of children in the country. My last group is what I've called medicogenic morbidity, which is us and the things that we do that tend to make children unwell. So we have our antimicrobial resistance, healthcare-associated infections, and then when we make diagnoses that don't actually exist, and this is particularly in the more affluent groups where food allergy and sensitivity produces malnutrition, misdiagnosis of ADHD when there's actually an underlying condition, and large numbers of children with undiagnosed quality of life affecting conditions. So 20 years ago, what were things like? We had 18 million children. We had services rolling out liberally, tobacco control improving, the child support grant was at 2 million children, it's now 13 million, and activism for child health. Many of us were shouting about HIV and AIDS when the government said nevirapine was a poison. And we had the negative of HIV, AIDS, crime, and macroeconomics at the time changing. So what happened in the next 20 years? In red was the bad stuff, and in purple was the good stuff. And let's see if we can make any of this purple stuff happen over the next 20 years. I would put advocacy and activism for children as something that has developed in this country, has made a significant difference. Breastfeeding came back after it's being dethroned by HIV choices, and new vaccines, which you heard about earlier. At the end of our period, COVID-19 made things bad. So what's going to happen in the next 20 years? Well, I'm guessing as much as you, but here are a few things for us to think about. Climate change. This is particularly to do with acute, but also chronic stuff to do with migration, heat, and other shocks that are going to continue. Around that is continuing environmental degradation and habitat destruction. And I would put urbanization within that, because when people move to cities, which they are doing, they're often living on the edge in very difficult environments. So what's going to happen with technological change, including artificial intelligence? Well, one thing it's going to do, I think, is going to increase inequality across the world. However, it may come up with some of those golden bullets and magic bullets that we're all looking for. I'm really concerned about governance over the next period. That was on my previous slide, that we've really seen a decrease in good governance over the last while with and what's going to happen next year in the election may actually dictate. But I'm not looking forward for. I don't want a right-wing people who will throw NHI out with the bathwater, because we need national health insurance. Even if we haven't got the money for some of it, we need to do what we can do to improve our quality of care and equity in the country. I like the idea that the community pediatricians now exist, and maybe a rising number of young community pediatricians can be what makes a big difference to child morbidity in 2043. Early life vaccines, the transition will continue with more NCDs. You don't know how many, you do know that adolescents have a lot of high blood pressure these days. That's going to get worse. We will have diseases of poverty, and maybe we'll see some lovely benefits of the first 1,000 days of nurturing care in child well-being in general. There'll be multipliers and mitigators. And how will these all have changed? Well, I'd love to hear your stories. And that's it. Thank you very much, Ute. That's my talk.
Thank you very much. That is fantastic. You also are pointing towards some of the sessions, the conference sessions that are still to come on climate change and on other modifiers in terms of child outcomes. So thank you very much. That really rounded off these presentations fantastically well. So we are going to have an audience Q&A now. So you can either put up your hand, or you can write your questions in the Q&A. And so if you do put up your hand, please, if you could just put on your camera if you can. And if you can then also just give like a one-sentence introduction. But yeah, and then I wanted to, and Dave is going to help me with the questions in the chat. So we've got one hand, and then after that is while other people are still thinking about their questions, I will be asking Dave then to ask some of the questions in the from the Q&A. So yes, and please direct your question towards a particular speaker, otherwise this is going to be a bit difficult. So our first question is from Belgium. Yes, hello. Go ahead. Thank you.
Can you hear me?
Yes, we can.
Unfortunately, I've got about 4 questions for 4 different people, so I'm going to have to limit myself. So I think this may be, I mean, it really is a question. It's a comment and a question put together. It goes across the neonatal and child, critically ill children, and reducing mortality there. And I think nobody will be surprised from those who know me. Sorry, excuse me. I'm a paediatric emergency specialist, and I worked for about 12 years in the Western Cape. And my role was a liaison. I basically was employed by the emergency medical services and worked as a paediatrician, sort of bridging the gap between transport and pediatrics and pediatric critical care, obstetrics, surgery, so trauma. So it was a fantastic role to be in. And of course, that gave me quite a lot of insight into what goes wrong at that interface. And we heard in the modifiable factors that transport. If you put those two, I think there was 3% each modifiable factors, 2 at 6% for transport and delays in ambulances, that comes up as one of the higher modifiable factors. So my sort of comment and question combined would be, there is, I think many people recognise a real gap in terms of what happens during the transport, the wait for the ambulance, all of this. And just mentioning that my own role there had been as a paediatrician employed by the EMS, do you think there is any scope for having this role in other provinces? Sadly, when I left that role, I believe that role disappeared. But I do think that it filled something that other people, because the EMS in themselves, when they do have medical people, they tend to concentrate on the adult conditions. And if you had, whether it was a paediatrician or an obstetrician, somebody who would then have a focus on looking at the newborns, the children, the premature babies, do the panel think that there is a potential, could we advocate, and I know in the current climate of budget restrictions and things that may not be possible, but for having someone in transport who then focuses on newborns and children. And for example, Professor Westwood will remember, we did a lot of work on periviability for the transport services, working on algorithms at the extreme margins of periviability, how to help the transport people to recognise babies that were viable and how to promote them and algorithms for that, as well as doing work on HIE and how to get babies faster for cooling to the centres that were doing that. Sorry, I've rambled on a bit, but I just want to raise this idea of working closer with transport, because, for example, in this conference, it would be fantastic to have people representing EMS from the different provinces, and then to work with them on closing those gaps that we see in the modifiable factors for neonates, premature babies, and children. Thank you.
Yes, thank you. So is your question directed to somebody in particular? I would think either Mandy or Neil, maybe.
Yes, perhaps maybe Neil covers the broader spectrum and knows quite a lot of the work I was doing. So maybe if he could comment on whether he thinks there's any scope for adding roles along that line.
Okay. Over to you, Neil.
Thanks, Ute. Thanks, Balchit. I'm a strong advocate for dedicated pediatric retrieval teams. I think if you look at the first world environment, particularly Australia and to a lesser extent the UK, they've had a dramatic impact in terms of improving morbidity and mortality amongst acutely ill children. And Australia works very nicely because the distances are so vast. So I'm all in favor of dedicated pediatric retrieval teams. The reality is funding to employ teams that can provide 24-hour service 7 days a week is a major barrier to this. With our road infrastructure, the transport would then need to be predominantly air rather than road transport because of our deep rural areas. And lastly, what we found with our dedicated obstetric ambulances in places like the Free State and KwaZulu-Natal is when they're not in use, they cannot sit idle while other ambulances are running helter-skelter trying to accommodate patients from all over a district. So they get diverted to address adult needs. And when you need them for children, they're not actually available. They're in transit with an adult going somewhere. So in theory, it's a wonderful idea. In theory, we should be advocating for it. But in reality, there are an awful lot of barriers that we need to overcome. We mustn't see them as an obstacle for not going this route. We've got to work out how to work within the broader context to ensure that we do preserve whatever resources are allocated for children, and they don't get stolen by adult-based services. Thank you.
Yes, Mandy, you also have a comment.
Thanks, Balchit, for the question. I actually wish that I had time to unpack the ambulance-related modifiable factors today, and it's something we could always look at outside of this. But in our area particularly, it's a massive struggle up in northern KZN with huge distances. And when we invite our EMRS to our CHIP meetings, they do come. And it's interesting, one of the things that they comment on is that they get tied up sitting at appointments of our tertiary referral center. And they say that that takes like 80% of their staff off the floor the whole day. They go to an appointment and they have to sit and wait hours with the patient, who then gets seen and then comes back again. And so obviously planned transport is one way that they can combat that. But when the patients are too sick to do that, they say that that is sort of the lowest hanging fruit of trying to get rapid turnaround of their staff at the arrival center so that they can come back. And then, as Neil said, the dedicated retrieval, although there were problems with the obstetric one in our area, it made a huge difference just for the clinic referrals, where the current situation is 7 a.m. referral. They all arrive at 3 p.m. when those other ambulances are freed up, with a huge waiting time. If you had somebody sitting at the regional center, one ambulance to nip out and fetch every child from the local clinics around or the district hospitals that are close, that would certainly decrease the waiting time. So I think these are conversations that need to happen, even though there's obstacles, and using the data, could start that conversation. So thank you for the question.
Yes, I see Sue also has her hand up. Sue?
Yes, I mean, I think the suggestion about better coordination of emergency transport is very, very relevant for obstetrics, for conditions like hemorrhage, where a woman can actually die within 2 hours if she doesn't get to the right place. And I think one of the issues, there are two issues, I think. One is how things are prioritized, and that needs ongoing input for people. And for example, ambulances don't, sometimes the system doesn't prioritize a distressed fetus in utero and the mother looks well, because it's two patients that have to be dealt with for emergency transfer. And the other issue is, it's not just having an ambulance. If a woman needs to be transported who's fitting or bleeding, unless it's a paramedic assisted ambulance, there is very little that can be done in the ambulance, and there's no staff to accompany the mother. And although in the Western Cape we may have quite a lot of paramedic assisted ambulances, in the rest of the country they're very, very few. So transport is just like an emergency car, without much happening in terms of maintaining resuscitation or treatment en route.
Yes, thank you for those points. Dave, over to you. Some questions from the chat.
So there was a question for Sufang about increasing mortality rates. Sufang's had to slip off to another UNICEF meeting, so we're going to send that question to her and answer on email. Mortality rate for older adolescents 15 to 19, so we won't be able to address that now. Haroon, do you want to address the question about the maternal vaccinations and mechanisms for increasing community demand for better health services?
Yeah, I'll try and do that briefly for both. So the maternal vaccine is certainly on the South African agenda. The NEGI, National Advisory Group of Immunization, are increasingly looking at extending vaccination to pregnant women. So I think it's on the agenda. So, for example, and its influence will mostly be in that neonatal period, offering the passive immunization during the period where newborns don't. So immediately on the card is pertussis. So DTAP now becoming part of the maternal immunization program. But I think some of the work in South Africa has shown the value of many of these vaccines, including RSV and even potentially Group B strep. So I see it in an arena in which there'll be increasing involvement. I'm not sure if there was a more specific part to that question, but that was my sense. In terms of hospital boards, I think I've been disappointed with any kind of community effort. Certainly during a survey, a midterm review we did of 21 districts around the country. This was around 2016, the midterm review of the maternal and child health policy. Many of the clinics and hospitals we visited certainly had hospital boards. But I think the problem with those boards is who elects them, and often the people on the boards are selective by the management systems, either in the hospital or often in the province, resulting in very kind of passive hospital boards who who really fulfilled a legal obligation rather than taking on the roles. And I don't think we've got many, I'm certainly not aware of many examples of effective hospital boards who are taking, or clinic boards who are taking on the issues for communities. Where I have seen difference is some of the more NGO or privately based organizations, including, for example, my experience is with Alexandra Clinic at in Gauteng. And previously, there used to be regular annual meetings where boards were selected by community. So it's finding the mechanism to involve community, but you used to get an annual day where communities involved. And certainly in those kind of fora, the community boards exerted much more pressure on the clinic staff, but also ensured that the clinic was assisted in responding to some of the community needs. So the short answer is I think we're still battling to find mechanisms by which communities can extract some accountability from our health centers. And I don't think hospital boards or clinic boards currently serve that function. Over.
Yes, thank you, Haroon. Can I ask the panelists to also continue answering questions in the chat themselves? There's a question from Perinatal Moodley. You can just put on your camera and introduce yourself.
My camera is on, but can you hear me?
We can hear you, not seeing you.
I'm sorry, I'm not going to be able to put my camera on.
That's okay.
I don't think I have enough bandwidth for that, but perhaps it'll come on. But
That's
hi,
okay.
I'm Prini Moodley. I am currently working in Carl Hospital in the Western Cape, but I have just some comments more on the line of what Baljit and Mandy touched on a little bit, which is the transport teams. Having had some experience working in rural KZN and now in the Western Cape, I think that it is a very important thing to consider how transport teams are actually utilized. And what we started here in the Paarl region, Cape Winelands and West Coast, is we started having meetings as an initial sounding board with regards to what sort of transport systems were available. So if I just take a second to explain, in the Western Cape, we have specialized retrieval team Sprint, we have our Air Mercy services, and we have local EMS teams. But the biggest problem is what I think Mandy also hinted at, is who goes where and transfers what child. And unfortunately, without the input from the regional hospital who's actually receiving the child, that is where a lot of the challenges occur. So even before looking at specialized retrieval teams, some sort of way of connecting all the different types of transport systems, transport teams, and how they actually rationalize who gets transferred with what type of transport and where they go and who's next, etc., makes quite a difference. So that's what we concentrate on in our transport meetings that we have. And then my second comment for the panel is rural medicine, rural critical care, rural patient transfer is a completely different entity from what happens in the center of our big cities. And this should be looked at as a niche on its own. That's my two comments. Thank you.
Great. Thank you very much for your fantastic points. So Dave, so I think, I mean, you've added more to the previous discussion, so that's great. I don't think we need to go back to the panelists now. Dave, do you have questions for us from the chat?
There was a question about from Michelle, is there data on compliance and monitoring HIV status as per guidelines in antenatal, postnatal mothers and children? I'm not sure, Haroon or Neil, do you know about monitoring HIV stats of monitoring HIV status in mothers and children?
I'll ask Neil to take this one.
Okay. You know, what we've got is tier.net, which captures some of the data, but I'm not aware of specific programs that are looking longitudinally at individual mothers and children. So we've got antenatal seroprevalence data for moms. We've got early infant diagnostic data for newborns, and thereafter there's a huge lapse. So I'm not aware of any routine system that is trying to link the two and follow beyond the infant period. Thanks.
Yes, and the whole, I mean, there've been several initiatives trying to do cohort monitoring of mother-baby pairs, but that is particularly difficult in our country because because our IT systems are not set up for that, and people move around a lot. So it certainly is a major gap. So I think we are going to move back to the panel, and I'm going to ask each panel member, and so you're not getting another 10-minute talk, you're getting a 1 to 2 minute input into, and the question now is really very focused. You've given us your inputs on your topic, and the question is now for each of your topics, what do you think will change the trajectory? So what is going to move the needle? So you can't choose 20 different things now. You can choose 1 or 2 things. And I'm going to start off with Sue. Sue, what do you think will move the needle in terms of maternal mortality?
I think involving community women in the communities via community health workers, and with a focus on adolescent girls. It's very much neglected in our inquiry. I think in terms of the health system, I would concur with what everyone else has said about clinical governance. I think there are issues of leadership and clinical governance for HR resources and ensuring minimum standards in facilities, and this should cover EMS. And I think we've already got protocols and training in process. We just have to carry on doing them. But I think the biggest 2 things are maternal, newborn and child health actually being given priority financially. And also I am concerned about this austerity budget, because I think it could be a huge spanner in the works for the progress we want to make. Thanks.
Yeah, thank you. So are you suggesting we have dedicated ring-fenced maternal child health
Yes.
budget?
Yes.
Okay. Okay, and how would we get there?
Well, I don't know, but I think when you look at single issue issues like HIV or COVID, they seem to always garner political and financial support. And because mothers and babies have been dying for hundreds and hundreds of years, they're just not being prioritized sufficiently. And I think it would have to start at national level.
Good, thank you. Over to you, Haroon. What are your two top takes?
So I have 3 on my list, and I'll quickly talk to them in the minute I've got. So the first we've long talked about is an essential package of services, both for neonates and children. And the problem with that is, I mean, that the promised land is National Health Insurance that will deliver these, but I think we'll wait forever if we wait for NHI to deliver. So the issue is, how do you get this essential package of services for newborns? And I think the example of what Neil and his team in KZN have done is quite useful, and Neil can talk to it himself in his minute. But effectively, they've been going from hospital to hospital, looking at the services, looking at the equipment, what have you, and almost grading services to say what quality of service, but more importantly also what kind of equipment and facilities are available. So some kind of active measures to get a uniform service at district and regional hospital level, and mechanisms for that we talk about. The second issue, particularly in urban settings, and I'm very familiar with Gauteng, is the reallocation of services. So we may not get more space, we may not get more staff, But certainly with the reduction in pediatric beds, particularly now that we've got fewer diarrhea and pneumonia deaths, the problem I still see is a lack of neonatal space, often contributing to infections. So I would like a lot of the pediatric spaces, certainly in urban settings, to be made available to neonates. And then with it goes the staff allocation, that the pediatric wards, if we can't get more staff, have to allocate more. And this is a problem throughout the country. I see district hospitals with huge neonatal nurseries with one staff nurse. So I think it's a reallocation within existing services. And then the last point I make, and this is a debate I often have with my tertiary care colleagues, is the prioritization. We know that a lot of that preventable mortality is in that 1,000, 1,500 group, maybe the 900. But increasingly, I see tertiary centers prioritizing, wanting to save 600, 700 grammars. And I mean, that's quite exciting for tertiary hospitals to do all of that. But I think that's the wrong focus. So the debate we need to have is, who do we prioritize? We have to prioritize, because just to finish up, the problem I'm seeing increasing now is that we save the 600, 700 grammars by giving them surfactant, elements of ventilation. They live up to 7 days, and then they get the infection and they die. And in that process, the wards get fuller and fuller. So there has to be a discussion about the prioritization, but a clearer focus on a higher age group. And I think those could all add to improving our mortality. The final point I want to make is that it's about basic services, that we don't need lots of ICUs and high cares. That's not the argument. And Sri Lanka is the best example of that. So in the last 10 seconds, Sri Lanka had a neonatal mortality rate of 40. They brought it down to 10 with only one center in Colombo that had an ICU. They didn't require ICU services to do that for the country. We at the stage where we're at 12 or higher, I think it's still basic services that needs to be the priority, and it's how we ensure that. Thank you.
Thank you. All great points. But hey, before you go, I have a question for you, Haroon. And the one is, how do we, on your first point, so how do we make sure that maternal child health gets embedded in the NHI system that is on the horizon?
Yeah, so as I said, my first point was, I don't hold up that much hope for NHI being, even the SDGs or global plans are not the answer. So it's not something that's coming from outside. It's us individually then continuing to advocate as we are. And we all accept that in these austerity measures, there was a question about how do you get health administrators, or one of the questions in the Q&A, to behave differently. And we're all struggling with that mechanism, accountability, and we've all resorted to advocacy. So the idea of plans, Tony, for example, has spent a lot of time talking through these plans. We've done some of the groundwork. What we haven't found is the key that opens it. I think if we had to propose what we need to do, what we want to do, it's easier. It's what we can't get is getting our administrators to accept that. And that's a whole debate on its own. Accountability from people who can make some of the difference. Elections are coming. Over.
Great. Thank you very much. Over to Neil. Neil, your 2 points.
Okay, I want to make 3 points. The first, Haroon has already alluded to. I think the starting point, because you have to address inequality, is a standardized, structured service delivery platform. And this is your essential package of care. We've been rolling this out in KwaZulu-Natal to try and get a degree of uniformity and address inequity. Once you've got that service delivery platform, you need a skilled workforce to actually be able to deliver care. And we need ongoing training again and again and again to keep our workforce up to date in terms of current evidence-based practice, and to have the structured platform, the skilled workforce able to deliver services to our children. We need ownership. And this is just another way of talking about governance, but ownership at a local level in each facility, ownership at a district level, ownership at a provincial level. Don't go as high as national, because they just interfere and they don't know what they're doing. So stick within your geographic domain and use the different levels to create a network of owners, so there's mutual support, guidance, and people are not left on their own, because ownership, not only by the clinicians, but also by administrators at each level, is critical. Without that, you will not succeed in turning around the outcome of children. Thank you.
Thank you, Neil. We can see that even after your your retirement, you are still full of your advocacy voice. So thank you very much. And I'm quite happy for you that our conference is virtual, because I'm sure our National Department of Health colleagues would otherwise be down your throat. But yeah, thank you for your summary. We're over to Mandy. Mandy, your 2 or 3 points.
Thanks, Ute. I'm not going to share it. I just want to open my slides so that I can remind myself. So for my recommendations, really, it's that at a facility, district, provincial, and national level, the modifiable factors can be used to guide where we prioritize our focus. So, you know, if these danger signs that are constantly missed and badly managed are coming up and up and up higher as they are, then it's something that we need to look at. What intervention, whether we pull the ETAT committee, the IMCI, the drivers of those programs together and say, why are we getting increasing modifiable factors related to these things? And the same with the ambulances. If in your area the transport is a huge issue and it's getting more and more in your modifiable factor codes, then a small working group sitting with EMRS needs to happen. So I think the first thing is to say, look at the trends in the modifiable factors, analyze them at all levels, and obviously we feed them back nationally to COMEC as the ministerial committee, but they can happen at facility, district, and provincial level as well. I agree with Haroon, although a huge percentage of our deaths were attributed on paper to lack of high care or ICU beds. If you really unpack the upstream factors, a significant portion of those kids probably wouldn't have needed high care or ICU if the other delays and recognition of danger signs earlier had not been there. So I agree with him that the basics is crucial. And then I think also to learn from the modifiable factors that are decreasing. So if we can look at how the HIV codes came down over time, little things like the PCR not being available or traceable, and those codes have virtually fallen away. And so if we can look at the areas where we made gains, what did we do well that meant that our malnutrition codes are coming up less often as attributable to the deaths? And why is our record keeping and investigations doing better and better and featuring less often as a modifiable factor? We can look at those, what did I call them, encouraging trends as an example, and see what we learned from those systems and apply them to the places where we're not doing well. So for me, that's just, you know, how we can use the modifiable factors to springboard our quality improvement drives locally and nationally.
Yeah, thank you very much. And Tony, over to you. We've got like 2 minutes left. So for your 2 points.
Well, thank you. I'll start with, if we talk about morbidity, we have acute morbidity and ongoing morbidity. So my first point is related to acute morbidity, which really is the vast majority of children who haven't died, who've had the kind of conditions we've been talking about today. And for me, that is around preventive, promotive, community, early intervention care. So even if we don't have NHI coming early on, the things that we know about community-based care and have been demonstrated in other countries and in good models in our part of the world, that's what we need for the prevention of those acute illnesses, and including the trauma side of things. If we can work at community level, at a whole of society approach, then we will do a lot for decreasing childhood morbidity from acute conditions, and there'll be less mortality along the way. And then for ongoing, I've got in my mind thrive and transform, because the ongoing is a lot to do with early childhood experiences. So what we know about the first 1,000 days, etc., we mustn't give up on that. Yes, it's a slow process, but we mustn't give up on early childhood and families and parenting and support of families bringing children up, because that'll make a big difference to many life trajectories in terms of nutrition, psychology, and many other things. And then we need to transform our thinking so that we are including and not getting hung up on mortality entirely, and realizing that there's a large number of children who need our care with congenital and acquired long-term conditions, who need a system that responds well to them. And that's also about packages of care and essential packages of care. You can have acute packages, you can have long-term packages, and we need to do it better than we do it at the moment. So that's transforming the health system for children to be thinking about long-term and morbidity as well as thinking about mortality. I'm not saying we don't do it, but the balance certainly needs to be taken into account. My last point, because I was allowed 3 as well, is if we don't change the international order, none of this is going to be easy to do. Really, the last 5 years have been very disappointing in terms of humanity's belief in itself, that it can actually make a difference. And we've gone backwards in terms of working as a one world. And I think we need to continue on a political level and an international level to be making a noise about the fact that we're one species and we need to do this together. Thank you.
Thank you for a fantastic summary, Tony. So I'm not going to add to that, but thank you for such a fantastic session. A big round of applause to all our speakers, and thank you for all the questions and all the interactions. This is really fantastic, and what a great start to our conference. So it remains to me to actually close the session, and please come back at 2 o'clock. So whether you now need to dash out and go and do your work, or whether you can go and have coffee, enjoy, and we will see you for the 2 o'clock session. So thank you everybody for joining this morning session, and keep well. We'll see you later.
Sorry, just before we end the session, just want to put in a plug for the executive committee election tomorrow. If you are inspired by the work of the CHPA, please submit your nomination forms before the end of business today, and we will have the election at lunchtime tomorrow. Thanks very much.